Before I get into introducing our distinguished panelists, I just want to kind of give a little bit of a backdrop of why we are thinking about non-communicable diseases, and just a couple of introductory slides to highlight that non-communicable diseases are not just a high-income country problem. This is a growing problem in low and middle-income countries. So that's one reason that we have to kind of pay attention to this. Historically, this is the 14th year of the Global Health Supply Chain Summit. In the past, we have primarily focused on communicable diseases. So that's where most of the work of the implementing partners is going in. And that's where, from a supply chain perspective, that's where most of the work is going on. But as organizing committee members, we've always had this at the back of our mind that we need to begin to focus the unique challenges, or perhaps even shared challenges between communicable and non-communicable diseases. So finally, we are able to feature this and then devote at least half a day to talk about some of these issues. So this is a growing problem. And as Dr. Stavros also highlighted, that one could consider this another epidemic that is there staring at us, that we need to think about this. However, NCDs have largely been domestically financed. So the question that comes about is, well, what's the role of global agencies in management of non-communicable diseases? Hopefully we'll explore some of these issues as we go along. What this is highlighting is the nature of the financing that goes in. And perhaps that's the reason why there has been a lot more focus on communicable diseases, because the financing is much more global in that perspective. And finally, what COVID has highlighted is that countries with high NCD burdens have higher COVID death rates. So this is a very strong connection between the NCD burden and anything to do with infectious disease pandemic type situation. So a few reasons why we need to begin to focus on these issues. So I don't claim to be an expert on NCDs, therefore I have assembled a great set of experts who will be on this panel. The way we will run this panel is we have 4 panelists, and I'll introduce each one sequentially. Each panelist will give their opening remarks, and then we will go into panel discussion. So to start with, I would like to introduce Mr. Chris Lim from the PAHO Strategic Fund. He currently is the Chief of Strategic Fund for the PAHO, stands for Pan American Health Organization, and is responsible for spearheading the development and execution of strategies to improve access of quality strategic public health supplies to member states in the region of the Americas. I mean, he has a long list of accomplishments. I'm not going to go through all that. All the bios are posted on the website. Maybe let me introduce the other panelists as well, and we will go sequentially. Dr. Shruti Chaudhary, she is with the Defeat-NCD partnership, is an experienced physician with an MBA from Duke and a Master of Medical Statistics in evidence-based healthcare from University of Oxford, and has significant leadership training from the GE Crotonville Leadership Institute. So Dr. Shruti Chaudhary. Then we have Helen McGuire. She serves as PATH's Global NCD Program Director, where she leads the organization, the development and expansion of the global program, offering strategic direction, technical guidance, and programmatic oversight of all NCD activities, including diabetes and cardiovascular disease in low and middle income resource settings. And last but not the least, we have Dr. Irene Weru from the Kenyatta National Hospital, where she's been since 2003 and currently heads their clinical pharmacy. She is the secretary to the Medicines and Therapeutics Committee at the hospital, and is also responsible for medicines formulary management. She's a member of the Coalition for Access to NCD Medicines and Products Technical Working Group on Demand Forecasting and Quantification. So I welcome all the panelists, but we will start with some opening remarks in that sequence. First with Mr. Chris Lim.
Right, thanks Ravi for the invitation. Good morning, good afternoon, and good evening. fellow panelists and everybody and all delegates. My name is Christopher Lim. I'm the Chief of PAHO Strategic Fund based out of Washington, DC. And I'm glad to have the opportunity today to share with you what PAHO Strategic Fund does and how we work with member states, specifically in the region of Latin America and the Caribbean region itself. Next slide, please. Now, for those of you who are not familiar with the PAHO Strategic Fund, I'll just give you a quick run through in terms of what are some of our value propositions, starting with the Strategic Fund's mission statement, which is to increase access to quality health products that improve health outcomes in PAHO member states. Now, first and foremost, we are uniquely poised to leverage and integrate our cross-cutting list of expertise within PAHO, working with working in an integrated manner with the different various vertical programs within the therapeutic areas to increase access of quality assured health products. Now, next is about ensuring quality, safety, and efficacy standards for the medicines that we provide, which is core to our mission statement. We're here strictly to the technical and eligibility criteria of WHO. Now, through the pool procurement mechanism and the concept of economy of scale, which we'll talk later, we can secure competitive prices through establishing long-term agreements, through competitive and transparent international sourcing, and to get the best value for the money. Now, our technical units will work with disease programs from countries to align the treatment protocols in accordance to the WHO recommended guidelines. And this will actually form the basis for the rational selection and the rational use of medicines, which is best suited for every different individual country's situation. Now, among which inevitably we can expect patent-related challenges, especially for the new treatments. Now, this is where we'll work with countries to evaluate the capabilities to utilize mechanisms like the TRIPS, Doha Agreement, and also collaborating with agencies like the Medicines Patent Pool. Now, in addition, the fund also promotes and facilitates solidarity and horizontal collaboration of donations and loans between countries, especially during times of needs. Now, the other unique feature that Strategic Fund has is actually the availability of the capitalization account, which allows member states to tap into a pool of money, right, as a line of credit for 60 days, which is interest-free, and actually help facilitate now cross-years budget allocation. Next slide, please. Now, well, there's definitely a lot of benefits, especially in terms of bringing affordability of medicines, right, into the equation for our member states through consolidation of demand, sheer economy of scale itself. Now, and this is especially true, right, for the smaller member states, where the demand is very often not even big enough, right, to meet the minimum order quantity of some of our major suppliers. And first, they are subjected to the mercy and the brutal forces of distributed supply chain. Now, over here, you will see that these are some examples of the potential cost savings based on our recent research. And we have witnessed, right, a potential savings ranging from, if you could see here, between 8% to 90%, just comparing prices of the Strategic Fund against those of our member states, specifically in some of the cardiovascular and oncology therapeutic areas. Like, for example, if you could see here is amlodipine, we've got docetaxel and also trastuzumab. Now, I know this is a very complex and very busy slide, right? It's my attempt actually to illustrate the end-to-end value chain or value stream and the various elements that's involved in this very complex supply chain for medicines and health technologies. Now, for those that you see that's been circled in green, now these are elements where pool procurement mechanism has traditionally done well. And then those in yellow are areas which I believe there could be room for improvement. And those that are in red are areas where we can and we really need to do more, right? Especially as part of the symbiotic operations, which I will elaborate. Now, we've seen earlier that there are obvious results of cost savings through economy of scale. And of course, the pool procurement mechanism itself do bring along with many other benefits, like, for example, centrally ensuring that producers meet all the quality standards technical specifications, GMP, GDP requirements, etc. Now, also at the same time, providing a constant governance and monitoring over the quality of the products being purchased and provided. Now, the process of international sourcing, supplier selection, procurement process are also made transparent and efficient. Now, at the same time, supply resilience for the region is being maintained in an equilibrium, and manufacturers are incentivized sufficiently to stay in business. Now, but at the same time, be able to continuously improve and provide year-on-year cost reduction in a sustainable manner, meeting green initiatives like reduction of carbon footprints, reduction of packaging, etc. Now, all this can be made very efficiently and effectively through the pool procurement mechanism, especially in a low-resource country. And it's definitely scalable from the policies, the organization structures, processes, and infrastructures that were established over the past decades from the work that we've done on communicable disease. Now, the pool of professionals and talents, right, that can actually be centralized into a pool, pool services, they can then help to continuously upgrade the service levels, expertise, and also, excuse me, and also continuously help to reduce the transactional costs to bring along best practices to member states rather than having them distributed and sub-optimized. Now, the question is, are these benefits sufficient? Apparently, to some extent, but not entirely. Now, there are other aspects which we need to address to further, to allow us to further enhance, right, in our increase of access, especially in the space of non-communicable disease. And we need to absolutely focus on what I will call symbiotic operations that can help us propel into the future. Now, due to the fragmentation, the extreme fragmentation of treatment protocols, especially in the NCD space, there is an absolute need in terms of streamlining, standardization, and alignment of treatment protocols in accordance to the WHO recommended guidelines. Now, this will both help with the simplification of treatment triage, but also at the same time enhance consolidation of demand. Now, after which we need to ensure that the treatment protocols are updated in the national EML list and also the national formularies. Now, through our work, we have also identified there's a lot of opportunities to enhance and fine-tune the various policies, right? Policies ranging from procurement, trade, taxation, prescription policies, so on and so forth. And also at the same time, having that fine balance, right, between domestic manufacturing landscape and that of international procurement. Now, all in all this, there's a lot of loaded topics that definitely deserve a much deeper dive for another day. Now, at the same time, we also need to help countries, right, strengthen their in-country supply chain management capabilities and capacities. Now, ranging from forecasting, planning, procurement, distribution processes, and infrastructures capacity building. Now, as we all know that there would be barriers around intellectual property and also the usage of generics and biosimilars. And this is especially true, right, for NCDs. It has been researched and observed that the lag between a drug's loss of patent protection and its availability to low, medium income countries can be as long as 10 years. Now, the existence of pool procurement mechanism offering to buy in bulk and also facilitate drug registration and approval could potentially shorten this lag, and it would definitely bring along huge benefits to countries. Now, finally, I would like to conclude by reinforcing that while traditional pool procurement mechanism has, and I want to emphasize it's a big has, right, allowed us to make huge strides in increasing access of critical medicines and health technologies to low middle income countries. But we can and we must do more to adapt with all this symbiotic operation which I've described earlier on. And also recognizing that every country is in a very unique and different situation, and thus us having this arsenal of services available to help customize and address their individual situation is absolutely necessary for us to go forward. Now with that, I conclude my opening remarks, and back to you, Ravi.
Yeah,
and this is definitely sorry,
Yeah.
just to elaborate, right? So for those of you who want to know a little bit more about Shruti Fund, these are the different websites to go to. Thank you.
Wonderful. Thank you, Chris. Appreciate that. So next we move to Dr. Shruti Chaudhary from the Defeat-NCD partnership. Please go ahead and give your opening remarks.
Thanks, Ravi. I hope you all can hear me.
Yes.
Okay, good morning, good afternoon, and good evening. Warm greetings from the Defeat-NCD partnership at United Nations Institute for Training and Research. It is a pleasure to participate in today's virtual discussion, especially on improving access to NCD medicines in lower middle income countries. Today, I would like to share with you the work of the Defeat-NCD partnership in low resource countries, specifically our work on the affordability and accessibility of essential NCD supplies and distribution. The Defeat-NCD partnership supports country programs to scale up their action and achieve a sustainable development goal 3.4 by 2030 by reducing 1/3 premature mortality due to non-communicable diseases through prevention and treatment. Our focus is on 90 low resource countries. Our practical work is overall organized around 4 interconnected pillars that constitute a comprehensive service package to tackle the most common gaps and constraints that challenge around 90 low resource countries. The pillars include national capacity building, scaling up of community health, access to affordable essential medicines and supplies, and financing. So talking more about pillar 1, national capacity building. As part of the national capacity building, we focus on making sure governments have institutional capacities, structures, systems, and financing in place to tackle NCDs. As part of this work, we have established memorandum of understandings with several countries, including Rwanda, the Gambia, Myanmar, and some others. Our team on the ground are co-located within the NCD units of the Ministries of Health, which are usually understaffed units, to provide necessary technical support and capacity building for NCD units. We start the engagement with the Ministry of Health by supporting them to develop National NCD Costed Action Plan, which is a detailed budget plan to help countries allocate resources, raise funds, and monitor the implementation of these NCD plans. Our support does not end at that point. We usually continue our support to the ministries to support the implementation, then the project monitoring, evaluation, reporting, and fundraising activities in support of these costed action plans. The Defeat-NCD partnership is usually requested to be the secretariat of the high-level multi-sectorial committee consisting of relevant ministries within the country, such as Ministry of Health, Ministry of Finance, Ministry of Trade, Education, Environment, Road Safety, along with development partners, academia, non-governmental organizations, and private sector. This committee is responsible to oversee and enable the implementation of this costed action plan. To give you an example, for our country programs in Rwanda, where the Defeat-NCD partnership was requested to develop national NCD strategy plan, in addition to the national costed action plan that we were already working on. The strategy was launched in September of this year. I think one of my colleagues is going to share the link in the chat box for the strategy. The partnership and Ministry of Health has been successful in raising more than $6.5 million in support of this plan from the development partners, which is in addition to supporting Ministry of Health to demonstrate the case for budget increase in domestic financing of NCDs. Now, going back to the other pillars of our work, Pillar 2 focuses on bringing more of the necessary NCD prevention and management services to the communities and people who need them the most. The Defeat-NCD partnership works with civil society organizations, community health workers, startups to work with startups to scale up efficient, startups to scale up efficient, affordable solutions to improve patient self-care and improve last mile delivery of the medicines and supplies. We also work with investors to scale up such initiatives. Pillar 3, now going back to our pillar 3, which is more around the enables a consistent provision of affordable essential medicines, diagnostics, equipment, and supplies for NCDs. We have established an essential supplies facilities with a comprehensive package of services. I think a lot of these have been already discussed as by Chris and then previously as well. The services to overcome the main challenges identified in the NCD procurement, supply chain management, and financing for public, private, philanthropic entities across our focus in the 90 low resource countries. Our service starts with providing technical support in terms of standardization of treatment, demand forecasting, and appropriate procurement planning to reduce the stockouts and ensure uninterrupted availability of quality assured supplies. The facility provides economies of scale, as has been discussed before. It's a pool procurement. So the facility provides economies of scale for NCD products. We want to make sure that the patients have access to fairly priced technologies to the treatment that they need without being pushed into the poverty. This can be achieved through the power of high volumes that the Defeat-NCD partnership at UN is aggregating across these 90 focus countries. The facility is also set to reduce a huge challenge of counterfeit medicines and supplies. We all know, based on the WHO report, that more than 50% of the essential medicines that are circulating globally in these markets are fortified products. The Defeat-NCD partnership essential supplies facility has stringent quality assured standards where we do pre-shipment inspection, batch sampling, and lab testing before even shipping of those products. The other major challenge for timely procurement of NCD supplies is, of course, financing and funding. Even in countries that have budget to buy the essential supplies, there are many challenges around the prepayment to suppliers or restrictions to payment in a foreign currency, delays in funds releases. So to overcome these kind of challenges, Essential Supplies Facility provides financial assistance mechanisms, such as flexible procurement fund, and support to the public, private, and philanthropic entities through a trade financing mechanism in collaboration with MIGA and IFC, with the first pilot, which is being launched for medical procurement through this facility. The facility is currently supporting procurement of low resource countries, such as Rwanda, India, Myanmar. Now, this was about the third pillar of our work. The last pillar of the partnership work is focused on sustainable NCD financing, generating the billions of dollars required to meet the global NCD targets set out in the Sustainable Development Goals. So this is not a grant-dependent facility. NCDs require huge investments, as we all know, that these are chronic diseases that sustain for a lifetime for patients, that the current funding constitutes only 1% of the international development funding, and which is definitely not sustainable. So we work with the governments on innovative solutions to increase domestic financing and attract investors to invest in the NCD care. I definitely would like to invite you all to contribute to the Essential Supplies Facility initiative to ensure that the vulnerable populations in low resource countries have access to affordable, quality assured essential NCD supplies where they need the most. Thank you very much.
Thank you, Dr. Shruti. Wonderful. We'll come back, loop back later with questions. Next, I would like to invite Helen McGuire. She's a global program leader for non-communicable diseases program at PATH. Let me see, I need to share the slide deck for you. Right, so yeah.
Super, and I'm going to scoot along pretty quick through these initial introductory slides, Ravi, so I'll just let you know as we move along. Yes. Thank you for this opportunity to join you today and welcome everyone. I really want to commend the organizers for having a session on NCDs and access to NCD medicines and products. We can go to the next slide. As Ravi said, I'm Helen McGuire. I lead off the Global Program of Non-Communicable Diseases at PATH, and also I'm the director of the Coalition for Access to NCD Medicines and Products. PATH is an international NGO with a decentralized regional structure where we have leadership and implementers around the world. We work in 70 countries and work towards eliminating health inequities. We can go to the next slide. As a result, of course, NCDs has been a big part of our portfolio for over 2 decades. And we recognize the challenge here, and Ravi has mentioned them in the introduction. NCDs is 7 of the 10 leading global causes of death, and 2/3 of the deaths for NCDs happen during people's prime productive years. We saw the impact of NCDs during COVID over the last 2 years. People living with NCDs were disproportionately represented in ICUs and in hospitals, showing the interplay between NCDs and communicable diseases and the importance when we think about global health security, we must think about the health of those living with NCDs. Next slide. The WHO has set a goal of 80% availability, and of course we wish to exceed that. Certainly in other areas of health, their goal is full supply, and this is certainly what people living with NCDs need. We can go to the next slide. PATH has been working over the last 8 years on really looking at access to NCD medicines and products, and what are the specific barriers to that access for people living with NCDs. And of course, some of these things you'll say, well, these aren't unique. But when we get underneath the causes of these, we start to see some unique challenges that are facing. One of them, of course, driven by the fact there is not donor contributions to the medicines. They were completely dependent on domestic financing. And typically in the past, priority has been moved towards acute illnesses and infectious disease. So we have shortages in stockouts. When individuals come and there are stockouts, they're forced to go to retail outlets with price markups. Typically, if one is not insured, there are catastrophic out-of-pocket costs relevant to securing their medicines. These are medicines they need for a lifetime, and they require consistent supply of quality medicines. Cold chain integrity has been a challenge for insulin, particularly cold sensitive NCD medicines. The management of the cold chain equipment has not been up to WHO quality standards, and there's been a lack of capacity. When it comes to distribution, some of these products are interdependent to each other, and yet they are often managed by separate supply chains. In addition, these medicines are concentrated at higher levels of care, making it more difficult for folks to access as they are not close to home or as part of the primary healthcare system. We can go to the next slide. What I'd like to do over the next few minutes is highlight with you some of the activities that PATH is undertaking individually and also with the Coalition for Access to NCD Medicines and Products. When we look at one of the key things behind stockouts is the challenge with forecasting. Ministries of health often come to us and say, we need an innovative approach to forecasting because our data quality, some of it we can't rely on, and yet we want to use local data. So consumption data is an example. Because of the extensive stockouts that impact NCD medicines, consumption data really doesn't reflect demand, so making it difficult to use that methodology. The Coalition for Access to NCD Medicines and Products joined with many stakeholders to consider what kind of an innovative approach can we use for forecasting. And we reviewed a number of data sets, local and internationally, to determine a combined approach to doing this. It's not a morbidity methodology, it's not a consumption methodology, it's a combination. And excuse me, when we're looking at that, we have really made a forecasting algorithm along with a user guide and a workshop training program. It incorporates elements of disease prevalence, local disease prevalence, health-seeking behavior, prescribing patterns, and clinical guidelines when we're working out the forecast with ministries of health and key stakeholders. So this program has been piloted in Kenya and Uganda and has proven to be effective in developing a 5-year costed forecast and mobilizing funds within these 2 countries. We can go to the next slide. Another issue that we have identified as a priority is not only the need and the challenge people have in accessing insulin. WHO notes over 30 million people cannot access the insulin they require, but there's a greater number of those that not only can access insulin, or some that can access insulin, but cannot access the products required for safe insulin administration. And here I'm talking about blood glucose monitors, strips, syringes that incur out-of-pocket expenditures. In assessments we've done, this has been up to 85% of the total cost of those on insulin is actually going towards these consumables. In addition, folks cannot secure these products in the same place and time. They're having to go to different locations, private retail outlets, etc. So we've used a human-centered design approach to create a bundling solution for insulin and their associated products. This has been piloted in Kenya and is now being moved to 4 new countries in 2022. We want to ensure that we can help folks to improve their clinical outcomes and be able to have access to, particularly monitoring, to ensure safe use of insulin. So as we go to the next slide, I'm moving through these really quickly, but really look forward to discussion, and I'll provide contact information for any of you who are interested in learning more. Cold chain has been mentioned. Ravi mentioned at the beginning of our session in summarizing previous discussions within this conference. It really does impact the availability of insulin, of quality insulin, particularly, and other cold sensitive NCD medicines. Some retail outlets won't carry insulin because of the need for cold storage. And within facilities, in our assessments, we found that there was a smaller percentage that had refrigerators at all. These refrigerators were not being monitored. Many did not have thermometers, so a challenge. Now, linking that to other work that we're doing at PATH, we looked at 10 countries with the Gates Foundation to determine what is the excess capacity within the vaccine supply chain. And for example, in the vaccine cold chain in Ghana, they are using currently only 13% of their capacity. And so currently PATH is leading an effort to bring together stakeholders such as WHO and UNICEF to look at how we can integrate insulin and other cold sensitive NCD medicines into the cold chain in Ghana. At this stage, we have a framework established and we're moving towards developing that further. We can go to the next slide. So as we look at access to medicines and health products, it really became clear through COVID the importance of getting these products down into lower levels of care and perhaps out into the community, using strategies that are used with HIV and other infectious diseases. Currently, these products are concentrated at higher levels of care. So focus of PATH is to strengthen lower level facilities. We're expanding access points, doing training, etc., but really focused on getting the medicines and products down into lower levels of care. We can go to the next slide. So as we go through these stages towards achieving that 80% availability or beyond, we're thinking through supply chain leadership, ensuring quality data, improving NCD care, treatment, and dispensing at the primary healthcare level, and moving towards reducing costs and increasing reliable access. We want to ensure that we're leveraging the learnings in infectious disease. Obviously, there's all kinds of capacity building that's been done in that area. But in addition to that, in working with our colleagues, supply chain colleagues in these other areas of health, we need to keep in mind that there are some specific barriers to NCD medicines and products that need to be recognized if we're actually going to achieve greater supply security. So we want to ensure that we, yes, leverage the learnings, but that we also target the unique combination of bottlenecks and barriers to access affecting NCD commodities, and so that we can provide lifelong access to medicines and health products to people living with NCDs. So I thank you very much for this time. And if you go to the next slide, the contact information is there. If you're interested in joining the Coalition for Access to NCD Medicines and Products, this is a multi-sectoral group focused on access for people living with NCDs. And my email is there. PATH serves as the secretariat for this coalition, so we'd be happy to discuss it with you. Thanks again.
Great. Thank you, Helen. That's quite comprehensive. We'll revert back during discussion to some more details there. Next, I would like to invite Dr. Irene Weru from the Kenyatta National Hospital, Nairobi. Wanted to have her to share, obviously, more specifically the provider perspective, but also how it connects to the other discussions we've just been having. Yeah, Dr. Irene.
Thank you so much, Ravi, for your invitation today. So today I'll provide tips on managing NCD medicines and care delivery, the challenges faced, some tools that we have, as well as the role of government support. So as an introduction, we have a big burden of NCD and it's growing, but most of our patients are either undiagnosed or they are not on treatment. And for hypertension, for example, about 23% prevalence with 15% diagnosed, so a big proportion not diagnosed and only 8% on treatment. And for diabetes, we have a prevalence of about 2.4%, 43% are diagnosed and only 20% are on treatment. So that's according to the stepwise survey. So big disparities in terms of those who access treatment. And then in terms of availability of NCD medicines, this is quite inconsistent within our setting. And from different surveys or assessments, we have about 40% availability of NCD facilities, with the empty shelf assessment showing about 31% availability, and from the Kenya Health Facility Assessment, about 42%. From the journey of the pill assessment, this shows a prolonged stockout of up to 30 days for tracer medicines only for non-communicable diseases. What this shows us is that with a lack of data on adherence and this prolonged stockout and a lack of financial support to a great extent, many of our patients will most likely at some point miss out on some medicines or select which medicines they would probably use. The health-seeking behavior of our patients with NCDs within our community, 61% of our patients will access care from the public health facilities, with about 26% accessing care from private facilities and the remaining from faith-based organizations. So NCDs continue to be a rising burden, especially in terms of hospitalization. And most patients will be seen in level 4 to 6 health facilities, that's at hospital level, according to how our health care delivery system is segregated. We have Kenyatta National Hospital, where I work, is the largest national referral hospital, and it's one of the 6 national referral hospitals within the country. So in our facility, most patients incur a high out-of-pocket expenditure, and this is unlike other chronic illnesses, especially the communicable diseases like HIV and tuberculosis, where treatment is provided for free of charge. Referral hospitals, the national referral and the county referral hospitals mostly procure NCD medicines from 2 main suppliers, from the government supplier, which is the Kenya Medical Supplies Authority, and from a not-for-profit organization called Med. For my hospital, we mostly procure through open tenders, and we have limited supplies under the universal health coverage from our national distributor. So at provider level, it is essential for us to have our medicines formulary so that we are able to quantify our products properly. Some of the challenges that we face at provider level is that we have limited tracking and capture of non-communicable disease data. And this is a challenge, especially in terms of planning and procurement. Some of the facilities do not have proper NCD tools, whether they are manual or electronic, and there are no specific resources allocated to NCD health products. as the resources are all consolidated into an overall pharmacy procurement. Protocols and guidelines that have been put in place are quite diverse, and a lot of times they are interfered with from prescriber bias. So that means that our requirements are not always predictable. At Kenyatta National Hospital, our outpatients will generally pay out of pocket because it's a referral facility, but those patients who are admitted with complications will usually benefit National Hospital Insurance Fund. In contrast, at the lower level healthcare facilities, patients are usually covered under the universal health coverage, but unfortunately, the availability of medicines is lower, and many times they will have older molecules that have been discontinued from treatment. For example, glibenclamide is still available in most of these lower level facilities. We have stockouts and managing contracts as a major challenge within our facilities. In terms of the tools that we have available, we rely mostly on hospital formularies and the country essential medicine list, and these help us to develop our procurement list, and we work very closely with our supply chain department. So for our orders, we mostly rely on consumption trends from historical data, mostly from our inpatient and our outpatient pharmacy units, as well as the stocks that would be held at the supply chain stores. We have short lead times for my institution, so we are able to liaise with our suppliers in terms of consistency of availability of stock. But that is not always the case for the lower level facilities. In the referral facilities, for example, Kenyatta Hospital, where I work, we have an amenity wing where we have provision to have access to an additional list of NCD commodities that may not be available in the mainstream pharmacies and that may not be aligned to the Kenya Essential Medicine list. In addition to the tools that I've mentioned, we have a daily monitoring of tracer medicines that has really greatly improved availability of NCD medicines. Previously, we reported monthly, but we have moved to a daily monitoring within our institution where we use simple tools like a Google spreadsheet, and different pharmacies within the institution are able to key in their availability daily, and that helps to identify gaps and to expedite procurement. Kenyatta Hospital is also a part of the NCD forecasting that Helen from PAHO has just spoken about, and we are hopeful that when this tool is implemented, we will be able to improve on our quantification and forecasting, and definitely improve on availability of the essential commodities for NCDs. Within our institution, we have cold chain management that is robust, but that's not always the case within the lower level facilities where they may not have consistent supply of electricity, and they may also not have refrigerators that they can use. We have some lower level facilities using solar, but again, the weather patterns are also quite unpredictable. And finally, having a robust electronic medical record would greatly improve on our monitoring and documentation of data for NCDs. And within my institution, we are currently at advanced stages of implementing an integrated EMR, and we hope that that will help us to improve on our data collection in terms of NCD. But in terms of the overall country EMR, we are at advanced stages of having an integrated system, and we hope that when we have visited systems, then our documentation will be a lot better. Thank you, Ravi, and back to you.
Yeah, thank you, Irene. Let's have all the panelists on the screen so we can move on with the question answer session. Wonderful. Thank you. That's as you know, I will kick off the question session, but I would encourage the attendees to post questions as well on the Q&A box. So thank you so much for those very comprehensive, outline of how you are thinking about the NCDs and what's going on, the different challenges. But as all of you, this is the question to anybody who wants to pick up. As you were describing this stuff, having looked at the communicable diseases, and this conference featured all of this stuff, many of the issues sound very similar. So we talked about cold chain issues, product shortages, forecasting of demand. If we just looked at some of those keywords in terms of, the supply chain language, you could replace NCD or communicable diseases, the same set of issues that the community has been dealing with. So I would love to hear from the panelists, about what do you see as unique about NCDs that is particularly, that needs some kind of a unique approach beyond financing. And I think all of you articulated that not enough money is going into NCD. So that's one big problem. But we can address that about what needs to happen, and would appreciate as global leaders what the appeal might be. But perhaps want to hear from you, what is unique about NCDs? Because the issues sound very, very similar.
Yeah, I can start maybe, and I think other colleagues can contribute as well.
Yeah.
So I think financing, you have already talked about it, and definitely is an issue. As I did mention before as well, there is only 1% of the international development funding for NCDs. And the other portion is even the donor funds that are available for any of these programs are very, very low. But I think I'm thinking more from a physician and a patient perspective here. These patients have to live on these medications pretty much most of their lives, whether it's diabetes or hypertension or any of these diseases, right? So it's the chronic kidney disease or any other diseases. So the one big problem with these patients is to have uninterrupted supply of their medications, so that they don't end up in a complications eventually that cause them more money and burden even to the state. So it's a little bit of that part as well. I think that makes it very, very important because it's most of the times the complications that lead to the increased mortality rates. So how can we make sure that it's a sustainable supply chain system to make sure that the essential medicines are reaching the patients on time, so that they do not miss any of these medications because of affordability. And especially when it comes to cancer and these kind of patients, it's very, very important. The time becomes very important on the staging and how are they getting treated and the money of it. So I think that's one portion I definitely would like to highlight, which is very different from communicable diseases, which are more short-term kind of problems to deal with.
Yeah, wonderful. Anybody, Chris or Helen, you want to add something to that?
Well,
Chris,
Helen, you want to go ahead?
No, go ahead. That's great. Thank you.
Sure. So for me, I think there are four very distinct areas, right, with regards to NCD that's different, right? So the first is around, I would say, the fragmentation of treatment protocols. Mm-hmm. I think in the NCD space, it's really fragmented, and purely because it's a complex. I mean, if you talk about oncology, you talk about cardiovascular, mental health, right? I mean, these are very complex chronic diseases, and the treatment protocols associated with them are just so varied. And therefore, as a result, that it's, as you could see in the pharmaceutical industry itself, every company has got their own solution to it, and therefore that makes a whole diversification of medicines available, and therefore, makes consolidation difficult. And therefore, I would say, and if you refer to my earlier intervention, right, whereby I think there's an absolute need from a disease area standpoint for them to really try to triage down the treatment protocols into a standard, treatment protocols, very much more streamlined. And I think, Ravi, I've mentioned to you before, one of the so-called, I can think of a good example that has actually done it successfully is the HEARTS initiative. especially addressing the anti-hypertension aspect of things. So that's the first part around the fragmentation of treatment protocols. I think the other difference, right, is the so-called focus by countries themselves. I think in the communicable disease space, countries typically take a very centralized approach. If you look at HIV, malaria, tuberculosis, they are typically being tackled at the federal level. And we're talking about big countries here, right? So the federal government to take ownership and accountability of addressing it as a nation. Whereas for the NCD space, many of the countries are actually kind of like decentralizing the approach and the way they tackle this sort of disease to the to the states, to the provinces, and all. And that sort of decentralization itself would definitely dilute the effort and the focus. And I think the third difference, right, is around intellectual properties. And that's a little bit associated with, I guess, the first point around the fragmentation of treatment protocol, right? Just because there's just so many such a wide spectrum of medicines and that's available, or treatment solution is available, and therefore, you have to deal with so many IP barriers, right, along the way. And the last point, and I think it's been also highlighted by several of the panelists as well, is really around the difficulties of forecasting. As I guess it's as purely because NCD is not as mature, I guess, as compared to the communicable disease space. So entities, disease areas are still grappling with a good model, right, that we can actually do a more accurate forecast. I mean, no longer based on mortality and mobility, but purely because NCD has got this big influence called social determinant of health, all right, which is a very, very unpredictable and a difficult problem to actually resolve, because it needs to be resolved sometimes at a government policy level, right, determining, especially to deal with the inequities and inequality within the different marginalized populations within the countries themselves. So with that, I'll say, it's just four major differences that I can think of. Back to you, Ravi.
Yeah, thank you, Helen.
Great, thank you. Well, we're certainly building the picture, and you brought forward some great points. The nature of the diseases, the number of manufacturers, the number of products in the systems, and the complexity, and also the lack of maturity of the supply chain system itself for NCDs. But I'd like to come back and highlight again one thing that is really impeding progress that there has been a lot of investment in from other areas of health, because Ravi, we don't want to focus on the donor situation and the financing situation, but however, there is that ripple effect from that. And the ripple effect includes very poor data systems. We're working with ministries of health to try to improve the data quality and the culture of use of that data to both ensure that services are distributed where they're needed most, but also, of course, to inform forecasting. In the meantime, developing an innovative methodology for forecasting that leverages the local data that is available. Let's look at what we have and not just what we not have, to try to at least refine and improve the accuracy of that forecasting in the interim. I think as well, when we think about demand and the market dynamics are very fluctuating, because this is an emerging area where awareness has been low. Even with healthcare providers, the focus has been acute diseases and infectious disease, and it takes a long time to shift that to also include and integrate NCDs into the thinking. So there has been a lack of, I'll say a lack of priority around here, or a lack of awareness. And so as that awareness builds, the demand will build as well. But the awareness isn't being raised on a gradual, slope, a steady slope. It's really influenced by a lot of external partnerships as well. So you get these fluctuations in the demand for these medicines and products as there's sort of artificial influences, if you will, as there's short-term projects that come in, do a lot of screening, refer those people to facilities for care. So important to have that linkage. And I would say as well, there's a real lack of transparency along the supply chain. Where are products? One facility will have a good supply, another facility with nothing, and there isn't a mechanism to identify in real time where those products are and how that can be drawn in so there's more equitable access across the country. So those are just a few things. I'm sure Irene has a couple of things. We have a couple minutes.
Yeah, Irene, if, as a provider, at a major hospital, how do you see the communicable versus non-communicable disease kind of differences? What's unique?
So I think for us, what's unique is what Chris Lim captured really well, the segregation of how we manage the non-communicable versus communicable. So for our communicable diseases, we get supplies from the central government, and our supplies are very specific for the treatment protocol. So we don't have disintegrated and complex treatment protocols for communicable diseases. They are more straightforward as opposed to how our protocols are for the NCDs. And I think that's a big challenge. And I think in addition to what's already been said, when we have patients requiring other health products like insulin syringes, for example, that complicates their access to treatment. And in addition, also, we have a bit of stigma in terms of some of these NCDs within the community. So some of these are seen as lifestyle diseases. And so there's a bit of stigma, especially for hypertension and diabetes. And then, of course, for mental illnesses, there's still the stigma that these, they are cases, for example. So that complicates access to treatment.
Yeah, thank you. Thank you. I have plenty of questions, but I want to give the audience some chance. So I see some questions here. One is, this is specifically to Shruti, as you think about, you talked about the 90 low resource countries. So there was a question about, how do you choose which countries you work with? What are the criteria for selecting these countries where you will intervene?
So for our initial country list, at least, we specifically focus on least developed countries based on the UNDP classification. We also focus on low income and lower middle income countries based on the classification as it gets updated. But at the same time, I think a lot of times we have seen inventory stockouts even in the upper middle income countries where they have reached out to us regarding these stockouts, and we have provided them support in those cases based on the humanitarian relief. And so it's a little bit of, we do focus on the low resource countries, but at the same time, we do make sure we have mechanism to support the upper middle income countries in case of stockouts.
So just to elaborate on that a little bit, when you talk about, so one is the identification of countries which you responded to, but when you work with countries, because of the wide scope of the nature, as was outlined by your opening remarks, and Chris in his last slide about the whole supply chain value system, it just was mind-boggling in terms of the scope. So, how do you decide? What is the mechanism? What is the process by which you decide with the country? What is it that you're going to help with or build capacity or assist? How do you choose that?
So for the essential supplies facility, we basically keep it open. But at the same time, when it comes to the national capacity building portion, we work we do communicate with the governments in details about their plans before signing a memorandum of understanding with that specific nation. And after that, we do have teams on the ground working with their NCD units to understand what exactly do they need for their particular country. For example, in case of Rwanda, road accidents and injuries are a big issue, and they are part of their NCD unit. So as part of our NCD strategy planning and cost reduction plan, we included road accidents and injuries in Rwanda. But on the other hand, in case of the Gambia, mental health is part of the NCD units, but road accidents and injuries is a separate unit. So in those cases, we are focusing on those portions. Similarly, in India, for example, India specifically asked for cervical cancer screening, prevention, treatment, support. So we are working with some of the states within India on those specific programs that are focused on cervical cancer screening, HPV vaccination, treatment. So it a little bit depends on the customization based on the needs of the particular area, the geographical differences as well. But I think we do go to answer your question. The first portion is we do engage with the government on understanding how much dedicated they are to the cause before signing up the memorandum of understanding and having a clear definition of how we are going to collaborate together moving forward. But at the same time, we do keep the essential supplies facility open for everyone. But these are very customized programs based on the needs of the countries.
Thank you. So Chris, if I may ask you, because in the Americas, you have so many different countries, and you showed, I mean, different countries, not only from an economic development perspective, but also needs perspective might be very different. So how do you, from the PAHO perspective, kind of similar to, the nature of engagement, how do you kind of deal with that?
Thanks, Ravi. No, I think it's a great question, right? But I just wanted to add, I think I would like to separate up two different topics, right? One is around capacity building, and the other is around the provision of essential medicines and health technologies. I think so I'll just tackle the essential medicines and health technologies first, right? I think for that, there is a need for this word called solidarity. And we actually do emphasize a lot of that within the Pan-American region itself, whereby, the bigger countries like the Brazils of the world, the Mexicos of the world, they absolutely have the financial and the economic and the political power, right, to do bilateral agreements with the big pharmaceutical companies, right? However, if we have identified that now there's a specific disease area that as a region or as a world, right, we want to address unilaterally and in a solidarity way, right? These countries, and that's how we actually do it, right? We pull them together with the smaller countries, like especially the smaller island states within the Caribbean itself, together with the big volumes from the Brazils, the Perus, the Chiles of the world, to collectively negotiate on a long-term agreement and a single price that's applicable for the entire region. And therefore, as a result, the whole region benefits. And for that matter, of course, I think this same concept can be applied to the world, right? And that's what I think WHO and us has been trying to do as well on several fronts. I think around pediatric cancer, that's one of the approach that we're trying to do on a global scale as well. And I would say recently, and perhaps Dr. Bente will later on talk a little bit as well around diabetics compact. So these are some of the examples. I think we should come together as a world, right? If it's a problem that's big enough and that deserves the attention, right? Just like how we're dealing with COVID, I think we should try to address it in a solidarity way. As a world itself, as a global landscape. Now, as far as capacity building and all, I think different countries has got different maturity curves, be it in terms of their capabilities from a supply chain management standpoint, or intellectual property standpoint, or for that matter, quality regulatory governance and so on and so forth. So I think different countries have different needs and different gaps, which an agency like PAHO, we would typically go in and do an assessment, right? Maturity curve assessment, to just see where is the most necessary and most critical needs. And then we will just have capacity building exercises or initiative from there. But it's definitely not a cookie cutter type of solution. It's very much need-based and it's a need-based assessment. I hope that answers.
Yeah, no, that's great, wonderful. A lot of the discussion we've had is around more, one is capability building on pool procurement, so ensuring supplies. There's a lot of challenges of shortages, etc. But if you think about supply chain, I think in terms of supply and demand, I mean, there is a huge need Irene talked about prevalence, etc. I mean, many of you talked about prevalence. So if I can map prevalence to need, but need does not equal demand. So, what kinds of stuff needs to be done or could be done by your agencies or other, global agencies or national agencies to convert need to demand? Because if that doesn't happen, first, of course, it is a big health issue, but you're not addressing, it feeds into the supply chain as well. So I would appreciate any thoughts you may have. Maybe start with Irene. I mean, how do you, and this probably connects also to maybe different ways of financing that you talked about, fragmented nature of care seeking. All of that stuff kind of feeds into that. But if there are any thoughts that you have about what you guys are doing in your country, Irene, or from later on from global agencies about this idea of converting need to demand.
I think having a centralized demand forecasting and quantification model will really help us to move to the next step in improving access for everybody, even at the lowest level. And the implementation also of the Kenya Essential Medicine List and the national treatment guidelines will also go a long way in helping us to standardize how we manage our patients. And that definitely ties on to demand forecasting and quantification, and as well as the work that we are doing across the country with the team from PAHO. Thank you.
Yeah, thanks. Helen, you want to?
Yeah, thanks. And as Irene was saying, as the supply becomes more consistent and more reliable, that of course will also drive demand as well. But as we think about it from the person living with NCD's perspective or those at risk, currently, people traditionally have had a health belief model whereby if they didn't have symptoms, they weren't going to seek care. And so there needs to be a lot of work done, and this is why we're really thinking about the lower levels of care and community-based work, is how do we reach out to people and increase their awareness of their risk, but also of their status of these diseases, and ensure that we link and track them to health facilities where a capacity building has occurred and that they are going to receive attention that's appropriate for the services that they require. So when we're looking at it, again, there's been a lot of initiatives in other areas of health that has proven successful in this. And there's also some great models that are currently being done in NCDs. An example is some work we're doing in Vietnam, whereby we've had some really innovative partnerships. So we've partnered with grocery store chains, with pharmacy networks, to ensure that awareness raising is really part of a person's day-to-day life. So they meet it as they go through their day, and they can actually increase their awareness, understanding where they're seeking their information. I know in Kenya, we did some work with the teams there to bring the clinics out to where the boda drivers gather, where sports events are on, because it's also around targeting that, right? To ensure there has been sort of a sense among folks that the lower levels of care are really for women and children immunization. But we need to expand that out because, of course, the prevalence of hypertension, for example, among males is very high. And so where are those people gathering? How do we reach them? So it's getting some of these services out of those higher level facilities, get them down where people are living and working, raising their awareness and driving that demand, but ensuring that when we drive demand that we're delivering, that we're linking them to service, and when they reach service, that it's of high quality. Thanks.
Shruti, do you want to add something to that?
Yeah, sure. I think as Irene and Helen has kind of covered most of the points, but I definitely would like to emphasize on, I think if you look at the prevalence and calculate the market size, it's pretty big. But when it comes to the demand portion, it's very low compared, because I think one of the big reasons is also undiagnosed cases. Prevalence is usually based on the sample data where they go and screen patients and understand the prevalence of a certain disease in a population, in a subpopulation. But when it comes to the undiagnosed cases, most of the low resource countries, you will see like I think we have a paper around it where more than 50% of the hypertensive patients do not even know they have hypertension before they develop a complication, which is either cardiovascular or some other complications that they show up in the hospital. So in those cases, even if there is a need which is I think below the water, which we are not seeing, in those cases, how do we make sure that these patients are identified early? So similarly, we are working on setting up NCD kiosks where it becomes very, very easy for screening these patients. For example, diabetes, patient doesn't show up usually till a lot of complications. For cancer, most of these patients show up in stage 3 and stage 4. Almost more than 80% of the patients show up in stage 3, stage 4, never in stage 1 and stage 2. And one of the reasons is screening. You will see in UK, US, and most of these developed nations, the screening programs are running on a mass level, and prostate screening, lung cancer screening. And I think that helps in identifying these patients early on to have that kind of demand versus the actual prevalence of the disease mapping. But in cases of the low resource countries, most of the times because of the finance and many other reasons, I think we do not have these kind of programs in place for screening of any of these diseases. So I think that comes back to the financing part as well, that we are lacking on the financing of these screening programs to start any of these programs to support the screening and early identify these patients so that they don't end up in the hospitals when they are too much complicated cases.
Thank you. Chris, do you have anything to add to that?
Sure, thanks. No, I just want to connect the 2 points which I think Helen and Shruti has actually mentioned, right? So one was around awareness and communication, right? And that is, I would say, is to deal with, I think, the social determinant of health. Just want to go back to that point, right? That I think from an NCD perspective, yes, as much as we want to do, increase the diagnostics, the detection and treatment part of it. But I think for the longer part of the game, right, we really need to deal with the prevention, which is the social determinant of health. I think that's one part. Now, the other was around the financing, which I think Shruti has mentioned as well. But I think all in all, right, just to connect these 2 points together is this word called political will. And I think end of the day, it's really that political will which the country or the nation or as the world, right, that we have. If we want to, if we have the will and the want to actually solve it, I'm sure we would have the ability to look for the right resources and the right methods, and the signs are all there. I think earlier on, not sure was it Helen who mentioned around not having medicines, which is or rather not having sufficient cold chain infrastructures, right, to support insulin and all. I think the science is there, right? I think we have got new analog insulins, which can be controlled at room temperature, transported at room temperature and all. But the problem is, are they affordable to the low resource countries, right? So that goes back to the earlier discussion around intellectual properties, around the ability to actually garner help and garner support from the industries itself and so on and so forth. So, but again, I think all in all this summarizes and goes back to the word political will.
No, so we are almost out of time. We are actually out of time, but I would like to take maybe, go around the panelists and one last, if there is an appeal, I think, this is building up on Chris, what you just said about political will. If there is an appeal that you would like to make to either national governments or global agencies, I know some of you are already global agencies, but it could be, maybe broader appeal for, NCD, management of NCDs, etc. What would that be? Just if the top thing on your mind, just quickly go around in 10 seconds each. So maybe Irene, start with you. If there is one appeal you have, what would that be? To either your
I think okay, so that would be to support the integration of care between NCDs and the communicable diseases, as well as support capacity building activities that are starting in a small way, But with political will that Chris talked about, and also with government support, that can act consolidated and we can move a step further. Thank you.
Wonderful. Thank you. Shruti?
Sorry, I think the part of the appeal would be to the governments and the public and the private entities that the kind of initiatives that are being available through Defeat-NCD or PAHO or PATH or other organizations out there, I think we need to make sure there's a certain commitment to go ahead and collaborate in those kind of initiatives to make sure that we can have pooled procurement kind of mechanisms which are working and providing affordable, quality assured medicines and supplies to the patients that need the most.
Great. Thank you. Helen? You're muted, Helen.
Yeah, excuse me, sorry about that. This is always a tough question because there's so many things that we can be talking about. But for me, I would really like to see the integration of NCDs when we're looking at global health financing and we're looking at health system strengthening, primary healthcare, that we expand that list. We often see HIV, TB, malaria, maternal child health in an integrated health system strengthening effort, but sometimes we don't see NCDs as part of that package. So just taking that more holistic view, remembering the incredible impact NCDs are having, the data is very clear, number one. And then as we do our efforts at lower levels of care, strengthening primary healthcare, I think is absolutely critical to ensure that we're achieving early diagnosis and treatment, that we focus there and we start to build those enabling policies to ensure that that care is provided as part of universal health coverage for non-communicable diseases.
Thank you, Helen. Chris, last word.
Thanks. So for me, just wanted to reinforce the three key words, right, that I mentioned earlier on. One is really around political will. I think as a world, as a nation, as a region, as a country, I think that's critical. And with that, together with solidarity within the region, within the world, and also at the same time, right, building on the successes, the infrastructures, the policies, the organizations, the processes that we have built on with regards to communicable disease, we can definitely bring them on and scale it up to the non-communicable disease space. Thank you.
Great. Thank you so much. I really appreciate the time. I think we're a little bit over time, and thank you so much. Let's give a big round of applause to the panelists. Yeah, thank you.